My gratitude to the ICRAP team, and I'm extremely overwhelmed to be in this forum. Thanks the Daradia Pain Foundation for this opportunity. So the cannabinoid is recently explored and an exploring entity in the pain medicine, and which is really going to come up in a big way in the armamentarium of our pain practice. So which has been an established concept in the West, but due to the regulations in India, like it has been banned for some time, and then now it's brought back in use, and everyone is going to actually use this in near future. So let's deep dive into this and let's see like how this particular medicine really works on the patient. So I don't have any conflict of interest. This being a pharma talk, like I have no, it's a self-funding, like no pharma is sponsoring me for this particular talk. So this, we all know about the incident of the chronic pain is on rise, especially in the young population. Like we see a lot of rise in the middle-aged, especially 30 to 40% of the prevalence in the chronic pain. Like sometimes we really get stuck, like how to go about with whatever the pharmacological or non-pharmacological methods we are available in treating the pain, especially the cancer pain is really tricky at times. So we will be exhaustive with all the options, and we still stuck, we don't know what to do. And having understood the problems with opioids, we all know the challenges we have in prescribing opioids, the recent the focus on that opioid-induced hyperalgesia, it's like slowly weaning off. So what is next in the pharmacological method of managing this chronic pain? So this is something really coming up in a big way with having a predictable pharmacokinetics and pharmacodynamics, and helpful on severe pain conditions where like we don't have any much hope to go about. So it has got a long history. It's not a new drug anymore. Like a lot of research has been done since the 17th and 18th century, but the main the developments has happened in cannabinoids since 1992 when they started discovered a product called anandamide. So that is one of the substrate of the cannabinoid, which was invented in 1992, which is the one like which specifically bind to the receptors. And after that, subsequently, they identified few other substrates like the arachidonyl glycerol. These two are the important substrates. I would like all of you to remember, like how we have the opioids, which binds to the mu receptors. Here we have this anandamide and the arachidonyl glycerol, which two are the main substrates of your cannabinoids. And of course, the enzyme systems which catabolizes these particular cannabinoids and make it as an inactive metabolite and excreted in the kidney as well as in the feces. So a lot of work has been done since 1992, and in 2017 the WHO has recommended CBD scheduling, and since then it has been a broad practice in use in India, especially after 2018. It has become so popular because the Ayush has taken over this particular product and then make it easily available and made any physicians to prescribe in a pain conditions. So there are three types basically. One is the endocannabinoids, which is already in the system, already in the body. Like we have our endorphins, enkephalins, our endogenous opioids. Like that we have our endocannabinoids, which is already inside in our body, produced in the brain. That is your anandamide and arachidonyl glycerol. Then what is called, second thing is called phytocannabinoids. Phytocannabinoids is the active ingredients derived from the cannabis sativa, which is the leaf of the cannabis. So there are many parts of the cannabis plant, but what has been used in India, I would like to tell you, it's mainly the extract from the seeds and the leaves, not from the flowers and the resin. The resin and flowers are banned in India. Of course, it has been approved in few countries, but in India it is only the extract from the leaves, which has been widely used in a various preparation. So that is called as phytocannabinoids. And the synthetic cannabinoids is not used much in India, but still we are expecting very soon the approval from the Indian Ayush Ministry or the integrated allopathic and Ayush Ministry for allowing the synthetic cannabinoids, which have already been in use in Western population, Western countries like UK and USA. So the phytocannabinoids, the predominant phytocannabinoids are like, the THC. We all know that's the most powerful component and the most efficacious component in the cannabis product. It is THC, we call it as, it is a tetrahydrocannabinol. Then we have got CBD, which is cannabidiol. These two are the main two components, but there are more than 80 cannabinoids which are explored from the leaves of the cannabis sativa, and there are other non-cannabis extracts which can still contribute to the analgesic effects like terpenes, terpenoids. So that also comes under the phytocannabinoids. But the two most important components which is worth mentioning here is the delta 9 THC and the cannabidiol. So the pharmacokinetics is like pretty much like any other drug. So it has got the same like opioids and other drugs. We have got the predictable pharmacokinetics with with how it is getting absorbed, and it gets metabolized by both glucuronidation and from the cytochrome enzymes. So if you see on the right side of the screen, like what are all the drug that can get interact with these drugs. So because of its property to inhibit the glycoprotein P and the cytochrome P2C9, we need to be little bit careful in administering this drug, especially when the patient is on anticoagulants like clopidogrel and rivaroxaban. So, and few drugs in chemotherapy called tacrolimus. So there are some drug interactions because of this the drug effect to inhibit these liver enzymes that can prolong the action of the other drugs getting metabolized. So how it works? It works by two different methods. One is like the peripheral method, another one is the central method. The peripheral method is because of the anandamide substrate acting on the CB1 receptor. The CB1 receptors are the most important receptors of the cannabinoid system, which is present in the spinal and the supraspinal and the spinal and the brain level. So it has got receptors in spinal level, supraspinal and the brain level. So these cannabinoids, this substrate gets bind to this receptor, and then it works exactly like your anticonvulsants and antidepressants we give for the neuropathic pain. We all know how the pregabalin works. The similar way, it inhibits the release of the excitatory neurotransmitters at the presynaptic terminal, and thereby it terminates the neuronal transmission of the pain. And by another method is like activating or augmenting the inhibitory descending pain pathway at the periaqueductal gray matter, which is exactly at the locus coeruleus level. So the norepinephrine release at the presynaptic terminal in the periaqueductal gray matter and the locus coeruleus will inhibit the release of the GABA, and thereby it augments the inhibitory pain pathway and thereby relieves the pain. So all these two mechanisms reduces the neuronal excitability. But what happens by in peripheral mechanism, where the CB2 receptors are there, especially in the immune cells, so that inhibits the release of the nociceptive substances like interleukin and tumor necrotic factor. So these two peripheral mechanism and central mechanisms reduce the brain transmission and thereby the perception of the pain. So this is the very typical predictable the mechanism of the action, like the ligands of the cannabinoids get attached to the CB1 receptors, and then it inhibits the cyclic AMP pathway, and then it activates the protein kinases. So by doing this, the calcium channel gets blocked and the potassium channel opens up. So that leads to a hyperpolarization at the postsynaptic terminal, and thereby pain signals get blocked. So one is like inhibiting the neuroexcitatory transmitters at the presynaptic terminal. Another one is activating the inhibitory pain pathway at the periaqueductal gray matter. Another one is third one is the inhibiting the release of the neurotransmitters from the immune cells. So these are all the three main mechanisms at which the cannabinoids work. So this is what we discussed at the periaqueductal gray matter, but there it stops the release of the norepinephrine, which is an excitatory neurotransmitter at the presynaptic terminal, and it neuromodulates both periphery as well as the central mechanism. So next comes to what are all the products available. You see there are many synthetic things available. Dronabinol, which is an exclusive THC product. The Nabilone is again the THC analog, but only thing is the dosages varies, and the nabiximols is the spray. These and the epidiolex is the pure CBD. It has got no THC. So these are all the things not available in India. I am just telling this for the completion sake, but it may come to India. These are all available. All these Western studies are based on these 4 drugs: the dronabinol, nabilone, nabiximol, and epidiolex. The 5th one is what we are using it in India. It is the tincture. So we don't have any synthetic phytocannabinoids to prescribe in India. We have only the natural substance. The tinctures, we are using it. We don't have a synthetic cannabinoids to prescribe here. So there are different routes of administration available there. The commonest used administration is the oral and the sublingual. The oral route has got a disadvantage of lesser bioavailability. It has got less than 10% of the drug reaches the systemic circulation because it goes through the first pass metabolism. Unlike your sublingual route, it has got 12 to 30%. 30% of the drug reaches the systemic circulation without metabolism. So the first pass metabolism is less if you use it in sublingual. So the onset of action is fast, but the duration is shorter. Unlike your oral, in oral the onset takes more than 1 hour to act, but the duration is prolonged. So that is the typical pharmacokinetic profile difference between these two different routes of administration of the cannabinoids. The inhaled routes are still not approved in India, unlike in other few countries, because of the secondary lung inflammations and chronic bronchitis fear, so it has not been approved. So these are all the dosage recommendation based on a modified Delphi criteria. Like they had made the International Association of Study of Pain made the consensus and the task force like how to prescribe these particular cannabinoids, but this is based on the synthetic cannabinoids routes. We are not started using synthetic cannabinoids, but it is going to come soon. So this recommendation is based on the synthetic cannabinoids. So how to use? First start predominantly a CBD product because the THC has got the psychoactive component. So like they may have some hallucinations and sort of dissociation. So try to start only with CBD and then give 5 milligram of CBD product twice daily, which is 10 milligram per day, and keep increasing it till you reach 40 milligram per day. 40 milligram per day is the maximum dose of CBD to start with. If there is no pain relief, then you can slowly start the THC. THC is the tetrahydrocannabinol, which is only 2.5 milligram per day you start, and then that also can be increased every 7 days till 40 milligram per day. This is a routine protocol which is followed, but we have got other 2 protocols called conservative protocol, which is like giving half of the dose. There we gave 5 milligram twice daily, here 5 milligram once, and then increase it gradually to every 2 to 3 days for 40 milligram per day. Instead of starting 2.5 milligram of THC, we have to start 1 milligram per day. So this is the conservative protocol is ideally suited for very frail patients, elderly patients, where you don't want to start with a high dose. We can start this conservative protocol. And we have got a rapid protocol. This is for a very severe pain, moderate to severe pain, severe cancer pain, like where you see like the routine protocol and conservative protocol doesn't work. You have to directly go for no trying of CBD, directly go for THC and CBD combination in 1:1 or 2:1 combination. So either start with 2.5 milligram or 5 milligram once or twice daily and increase it till maximum of 40 milligram per day till you get that. So there is no recommendation advised more than 40 milligram based on the synthetic cannabinoids. So the treatment goals are pretty much good quality of life, good sleep, and good the reduced dose of opioids and benzodiazepines. These are all the benefits what you achieve in cannabinoids over the opioid usage. So like assess the patient every 2 to 4 weeks to start with. Once more or less the dosage is stabilized, the review is every 3 months. If the patient has got any discontinuation, then you can ask the patient, or any adverse effects, they can come and report to you anytime. So these are all the contraindications. The psychiatric illness, of course, yes. Pregnancy, breastfeeding mothers, no. And the liver failure patients, you can using a oral preparation is a little challenging because of the first pass metabolism, but still you can use the sublingual route. So we have obviously a greater advantage of cannabinoids over opiate because it has got no risk of the respiratory suppression, and the risk of dependence is less when compared to the opioids. and it has got a great opioid sparing potential. So, of course, there is a risk of cannabinoids dependence due to these various mechanism of action. So in that case, like, better to avoid the high potency THC to start with. As I said, start with only CBD, and then if there is no pain relief, then you can go to THC and CBD combination, and then the addiction is more and the dependence is more when you start at the very younger age. So in case of addiction and dependence, the treatment is again the nabilone because of its partial agonistic action. So the patient can come out of the dependence slowly. So the gradual tapering of 10% every week along with nabilone can deal with the dependence part of the cannabinoid. So there are many studies supporting the usage of the cannabinoids. The one such is Johnson, who was done 2010 in cancer pain, where there is more than 30% reduction in pain relief in 40% of the responders. And the Wiley has done it in inhaled cannabis in neuropathic pain, again showing a very good response in pain relief with a good statistical significance. And the Serpel has done in a peripheral neuropathic pain with a good promising results in pain relief with more than 30% reduction. And Husser et al. Has done a very good thing in general chronic pain and then proved its efficacy is much, much better than the opioid usage. And there is a study done by Andrea and multiple sclerosis. Apart from treating the pain, the muscle spasm seems to be relieving along with it. So there are many Indian studies are also available, but they are all like, more of the case study basis, not a proper RCT. So like we need more of an RCT to get the consensus in future. So in pediatric population, still, the use is not recommended because still we don't know the growing brain, how the receptors are going to be, the CBD receptors are going to be in the brain. So as such, it is not really recommended for the pediatric population. So that is what, so the efficacy of this particular cannabinoids, I will take 2 minutes, I'll finish it. So the efficacy is more with neuropathic pain as a whole. Even in cancer pain, it is more effective in the neuropathic pain. And for multiple sclerosis, it is of great use, and also in fibromyalgia. These three are the grade 1 or grade 2 evidences for the cannabinoids use. So these are all the regulations set by the Indian government. Like, in 1985, this was under the narcotic drug prescription. But in 2018, they have removed these particular cannabinoids from the narcotic drug and made it available in Ayush medication and made all the prescription practitioners to prescribe. So 2018 is a major breakthrough in India where this product was taken out of the narcotic drug and then it was put back into practice, and every clinician can prescribe this safely, and it has been removed from the Schedule 5 and added to the Schedule X drug. The Schedule X drug, when you prescribe opioids, you have to give triplicate. So you don't need to add triplicate here, just your prescription is enough. So various countries has various regulations, but it's like more of, there is no, except in Australia and rest of the countries, it is like prescribed medicine. Only in Australia, this is available as over the counter. So a lot of regulations are there, we discussed it before. So like understand the pharmacology, that is very important, and the right indications we discussed. It's more of a neuropathic pain, cancer neuropathic pain, and fibromyalgia are the well tested indications which gives very, very promising result. And know the local regulation, how much to prescribe and all these regulations. And more important is like still lot of studies are important to extend its usage to the other conditions as well. So this is definitely going to unfold the management of the complex neuropathic pain syndromes. Thank you so much.
Thank you for very nice and informative talk. I want to ask one question. There is no evidence, and जो evidence है वो these are towards the neuropathic pain. So I think there is less of evidence and needs more RCTs, more meta-analysis, and more case study. In India, there is no availability, I think, cannabinoids.
Oh, it is available.
It's available.
Yeah, it is available.
So which form? CBD or
It is available in capsule forms, and it is available in a tincture form. Tincture is the sublingual route. So these two forms are the recommended forms. Of course, there are many pharmas are giving topicals, sprays. That is like, not a very good evidence-based formulations. but the oral form and the sublingual forms are available in India, and which has got the predictable pharmacokinetics and dynamics.
Okay, and it does not require the procurement like morphine or narcotics. It is available at every pharmacy.
No, it is available
in the West countries, but
Yeah.
here in India it is not available everywhere.
It is available. The pharmacies are stocking it, and again it needs prescription. It is not a over-the-counter drug, and
Yes.
any medical practitioners can prescribe it.
Yeah.
And most important thing here is the indication should be only for painful condition, because these cannabinoids can be used for mood elevation. This can be used for insomnia. This can be used for muscle spasm. So, but your diagnosis should be involving a painful condition. Only then it will be allowed to prescribe.
Okay, thank you. Any question from the audience? Yes.
No. Yes, please.
Have you seen the use of more than 40 milligrams of THC per day? Because the psychiatrists in the UK use much larger amounts.
Actually, this is based on that's what, like, the individual practice preferences is different. This is based on the IASP. IASP has come with a task force. Like, you need to have a task force. How much to use? It's a guideline. It's a guideline which says 40 milligram is the maximum dose allowable, but it can go above it based on individual patient choice and the clinician's choice. This is a guideline and task force set by the International Association of Study of Pain based on the modified Delphi's process.
Yeah, thank you.
Thank you. Yes, sir.
What you say about a capsule and tincture form. Few days back, one company came, I do not forget the name. I do not recollect the name of the pharmaceutical. They introduced the drug with the spray form also.
Which ones?
This cannabinoid spray.
Yeah, spray is there, transdermal patches are there. There are various.
As you have said,
See-
that only capsule and tincture is there. That's why I asked you.
See, the recommended
Very
products.
limited,
I
knowledge is
completely
there
agree.
with me.
See, the thing is, there is no proper dosage recommendation for the oral sprays and the transdermal. And why I have not discussed much about the sprays and transdermal patch, because they lack the pharmacodynamic and pharmacokinetic profile, unlike your oral and the the tincture form.
Tincture.
Because we know like how much of each drop you give.
Yes.
How much of each drop you put under the tongue, what dosage is that, and what is the maximum allowable dose, it's all like set. Unlike you have got that oral spray and transdermal, it lacks the pharmacokinetic profile. So that is the reason only these two forms are like advised to prescribe.
That is, evidences are there
Yeah.
for the tincture and that.
Yes.
And for the spray.
Evidence
you
is
can-
there for even inhalational cannabinoids. Unfortunately, in India, it is not allowed.
No,
There
I just asked about the spray form. It is not having any consensus that how much cannabinoid will be absorbed from the spray form.
From spray, that's what the spray really lacks how much, because
yes.
the bioavailability, there is no proper, if you see my talk there, I didn't mention
yes,
about
I-
the spray part much. The bioavailability is not clearly explained in spray. Unlike your sublingual route and your oral route, the spray part, we really don't know how much of the drug getting absorbed into the systemic circulation.
But they are marketing.
No, the
It
marketing is
it is
different.
only 15
Yes,
days experience of me.
Thank you,
before.
doctor.
Thank you.
You can ask at the tea time. We are getting
Thank you,
late.
thank you so much.
Already we are late.
Okay,
Thank you.
thank you.
Thank you so much.